Hey guys, Cody Warner with Idaho Medical Academy. Today we're going to be going over the trauma assessment sheet step by step to help you crush that trauma scenario. Okay guys, looking at this skill sheet, I know it looks intimidating. I know there's a lot of steps. We're on a trauma, so we want to be really quick. But again, remember, this is a testing scenario. These are practice scenarios. Nobody is actually dying. Your proctor wants to make sure that you're going to hit all your points and that you're a competent EMT and a competent test taker, okay? So, starting off with the skill sheet, we want to break that skill sheet into boxes, okay? Again, if I'm seeing my scene size up, I'm looking at it, I'm going to put that scene size up on a note card, I'm going to flip my note card over at home, and I'm going to write down every single point in that. I'm going to do the same thing for primary, I'm going to do the same thing for secondary, okay? When I'm trying to memorize the skill sheet, I'm not going to do it all at once. I'm going to do it block by block or box by box, okay? Once I have scene size up memorized, then I can move on to primary. Once I have primary memorized, I can move on to my secondary. Okay, so memorize the skill sheet before you start applying it to scenarios, or before you really start getting into it. Memorize it step by step, okay? Our scene size up starts as soon as we get the call, okay? So when we're sitting at our station, we get dispatched to a motor vehicle accident with a 25-year-old female on the freeway. My scene size up is now beginning, okay? So I'm gonna get into my ambulance, or I'm gonna get into my fire engine, and I'm gonna go ahead and put on my PPE, okay? I'm gonna make sure that my scene is safe. Now, does this mean I'm gonna get on scene and determine safety? Most of the time, no. Most of the time, dispatch is going to tell you to stage, okay? Or that we have PD en route. For something like a vehicle accident, we're just going to go to that call and make sure we're staying safe. So we're wearing our vests, or we're parking the correct way, or PD has traffic control, okay? Now, something like a stabbing or a shooting, we are absolutely going to wait for PD to get on scene and determine the scene is safe before we show up. And again, that is something dispatch is going to tell you while you're en route to the call or prior to you being en route to the call, okay? So scene safety and PPE. Then we're gonna determine our MOI or our NOI. Now I know this is a trauma, so this would be a mechanism of injury, okay? So I'm gonna tell my proctor that my MOI is a car accident, or my MOI is a stabbing or a gunshot, okay? Or a fall, things like that. Those are examples of an MOI, okay? Then we're going to move on to my number of patients. So with a vehicle accident, we might have multiple patients, okay? But you were called to a 25-year-old female. So it is safe to assume at this time that you have one patient. So I'm going to tell my proctor, sounds like I have one patient, 25-year-old female who's in a vehicle accident. Now, once you get on scene, things can absolutely change, and that's okay. It doesn't mean you're going to fail that point, but right now you know you have a 25-year-old female, okay? The next point is going to be requesting ALS. So in a testing scenario, you are always going to be requesting ALS, okay? Not every call needs ALS, but in testing, we're always gonna request it, okay? And then that last step is C-spine precautions. Are you gonna be taking C-spine precautions? Simple yes or simple no. For an MOI, I will always be taking C-spine precautions. So I'm gonna tell my proctor, yes, I am taking C-spine precautions, okay? Now I'm going to move into that next box. I'm not going to be jumping box to box and asking this question now and then coming back to this question. It is step by step. That is how these sheets are laid out. So starting my primary survey, I want to get a general impression. Now here at our school, we cannot create a car accident on the freeway. So you are going to ask what your general impression is, okay? So it looks simple as I'm getting on scene. What does my general impression look like? Okay, you show up, the vehicle is into a pole, the patient is sitting in the car, looks like airbags are deployed, she looks to be moving her head. Perfect, okay? What's your next step? You're gonna assess level of consciousness, okay? So now you're gonna go up to that patient, you're gonna say, hi, my name is Cody, how are you doing? Or what's your name? You are wondering what her alertness is on that AVPU scale. Is she talking back to you? So she's alert. Do you have to get in her face and yell, ma'am, can you hear me? Then she would be alert to verbal, right? I'm telling my proctor, my patient's not alert to verbal. I'm gonna move to painful stimuli. My patient's also not responding to painful stimuli, so my patient is unresponsive. I'm going to move on. Or it's as simple as, okay, my patient is alert. Again, now, if you are not saying each point and each step and you're not reiterating to your proctor that you know the skill sheet, you're not going to get the point. So take that slight pause. My patient is alert. I'm moving on. Ma'am, what is hurting you right now? Or what is your chief complaint? Okay. Did dispatch give you a chief complaint? No, they just said car accident. So there could be 20 injuries or there could be absolutely no injuries. Okay, we'll say this patient says her ankle hurts, her arm hurts, her chest hurts a little bit, and her neck hurts. Okay, perfect. Her chief complaint is multiple injuries. I'm telling my proctor, multiple injuries. Okay, now typically we want to jump in and start treating because that's what we do as EMTs. We want to bandage the ankle, or we want to splint the arm, or we want to check the chest, which typically on a call we would probably move that way. This is a testing scenario and you're trying to get points. So take a breath and remember, you got to get through your ABCs first, okay? So we're going to move into our A. Again, I'm looking for life threats initially, meaning any major bleeding or any reason she's not breathing or if she doesn't have a pulse, okay? So that's a quick check. I'm looking for breathing, checking for a pulse, or I'm doing a blood sweep, okay? If your patient is bleeding, your proctor will tell you, once you walk up to your patient, you notice a pool of blood. It is time to find that bleed right now. Before anything else you do, it is time to find the bleed and stop the bleed, okay? So I got a chief complaint. Do I see any life threats? Proctor says no life threats at this time. Perfect. I'm going to move on to my ABCs. Is my patient talking to me? Yes. So my airway is clear and patent. Typically on our trauma scenarios, your patient is going to be unresponsive. So now you need to assess that airway. And how are we going to do that with a trauma patient? Well, we're going to do a jaw thrust. I'm going to tell my proctor, I'm going to do a jaw thrust and look into the airway. Feel free to now have a partner put on a C-collar or at least hold C-spine, okay? So we're going to assess the airway. If there's blood in there, if there's vomit, if there's spit, we are going to suction it out to open up that airway. If they're unconscious and unresponsive, I'm probably going to go ahead and try to drop an OPA into their mouth to keep that airway patent. Remember though, we are worried about their neck, so we don't want to do a head tilt chin lift or move their head around a bunch, okay? So I have my airway controlled and managed. Whether I put an OPA in or it's fine on its own, I'm going to move into breathing. Now, these mannequins do not breathe on their own, okay? So I have to ask my proctor, what is my rate, rhythm, and quality? Proctor might tell you it's shallow and slow, or they might actually give you a rate. It's 4 times a minute, it's shallow and agonal, okay? Or they might say it's 20 regular normal. Now you make the decision, are you going to fix it now or do you not need to do anything? If something is affecting ABCs, we fix it right now. If they have a broken bone, that is not a life-threatening injury at this point. If they have a broken arm, right? So we're going to save it to the end. They're not breathing, they are dying. So we need to fix that right now. So let's say our proctor tells us it's 4 shallow and agonal. Say, all right, I'm going to have a partner go ahead and begin BVMing my patient at 15 liters per minute. We have an OPA in place. Okay? So my patient's completely fine. They're 20 breaths a minute. They're talking to me normal. I'm going to make sure my proctor knows that I know I don't need to fix their breathing or treat their breathing. And I'm not going to put on oxygen, or I am going to put on oxygen. Okay? Remember, you have to justify what you're doing or what you're not doing to get full points. Moving on to circulation, okay? In our life threats, we looked for major bleeding, but you have another point in circulation that is checks for major bleeding. So I'm going to ask my proctor, again, do I have any major bleeding? If he says yes, well, that's a new surprise. I'm going to find it and I'm going to fix it. If not, I'm going to move on. So I'm going to check my pulse, rate, rhythm, and quality, just like I did breathing. If they're unconscious, I'm going to check a carotid pulse, rate, rhythm, and quality. Okay? Then I'm going to assess skin, color, temp, and condition. Okay? For our normal patients, right now, like me, I'm pink, warm, and dry. I'm good. I'm healthy. I'm not hurt. For our trauma patients, they could be pale, cool, and clammy, pale, cool, and sweaty, which are signs of shock, okay? Meaning they're severely injured or severely sick. We want to treat for shock, okay? Right now, we're going to treat for shock. So we are going to put oxygen on them. Even if we didn't in breathing, now that they're in shock, we're going to go ahead and put oxygen on them. I would go ahead and put on a non-rebreather at 15 liters per minute. I'm going to be specific, and I am going to have good attention to detail. I'm going to tell my proctor, non-rebreather, 15 liters a minute, or nasal cannula, 4 liters a minute, okay? Be a good EMT. We're going to have them flat and supine, right? So if we're in shock, our blood pressure is probably really low. Okay, if we stand this patient up, they're going to get dizzy and pass out, or blood isn't going to be circulating as well, so we want to keep them nice and flat. Okay, and then we want to keep them warm. Typically on scene, right, we're on the side of the road or we're in a house or something like that. I'm probably going to worry about keeping them warm in the ambulance. Now, treating for shock is your point, though, so you now have to say that right now. Okay, and we're going to move on, A, B, C to D. Okay. This basically means disability. We are going to get a GCS. So that Glasgow Coma scale that you guys have been practicing or you've been reading in the book, you are now going to determine your GCS of this patient. In our testing scenarios and our practice scenarios, you are allowed to have this on a note card. I recommend memorizing any and everything you can because I don't carry note cards with me in the field. So the earlier you learn it, the earlier you memorize it, the better off you're going to be. But you're going to determine a GCS of this patient. Remember, patient talking to you, completely alert and oriented, no injuries, is going to be a 15. A completely unconscious patient is going to be a 3. Okay, so if they're anywhere in the middle of that, you need to pull that note card out or go based off memory and get their GCS. Okay, now you need to determine if that GCS is due to injury. Okay, that disability due to an injury. This can get a little confusing, but think of it this way. If we have a dementia patient who normally doesn't know the year or doesn't know their name or has no idea who the president is or the day of the week, right? Their GCS is normally going to be a 13 or a 14. That's normal for them. So we go to a care facility for a patient that fell and hit their head. I'm asking them these questions. Do you know the president? Do you know the year? And they're answering these crazy answers. I'm going to look back at the CNA or whoever's helping this patient. I'm going to say, is this normal for this patient to not know these answers? If she says, yes, she has dementia, this GCS is not due to injury. This is normal for them, okay? Now, I just went on my 25-year-old female who was in a car accident, and she's not answering me. She only flinches when I pinch her trap, and now she has a GCS of, let's say, 6. This is probably due to the injury, okay? So that's how you can justify, is it due to injury or is it normal to baseline? Okay, then we're going to move to E, okay? Let's say this patient's unresponsive. She can't tell me what her injuries are. So one thing I'm going to have to do is expose. Now that my patient is exposed, I can see their injuries. Now you might be asking yourself, like, would I expose this patient on the side of the highway? Now, if there's a major bleed, absolutely. I'm absolutely cutting pants. I'm absolutely cutting off the shirt to see where that bleed is coming from, okay? Now, if I don't have any major bleeding, but I see maybe some swelling on the leg or swelling in the arm, something like that, and they're in a sweatshirt, I might go ahead and do it depending on time, but most likely I'm going to get them loaded onto a gurney and get them in the ambulance, and I'm going to expose there to where I can also keep them warm. Another question you might have is, well, how can I keep them warm and expose them at the same time? Keep in mind we have heaters in the ambulance, and we're probably going to crank that heat up. Sucks for us because we're going to be sweating really bad, but it's key for your patient to stay warm. So expose comes in that primary because we want to keep it A, B, C, D, E. Okay. Now we're going to move on, and we are probably going to make this patient a high priority, and we're going to be transporting. Remember, on trauma patients, we want to stay on scene for no more than 10 minutes. Okay. We don't know what bleeding inside could be going on. We don't know what's going on inside their head. We want to be on scene for no more than 10 minutes. So we do that rapid primary survey. We get that gurney up close to us. We get them on, and we get going. Okay. Kind of figure everything else out in the ambulance. Fix what you need to. ABCs. Don't worry about broken bones. We'll get them in the ambulance, okay? Now we're going to move into our history taking. Here, now that we're in the ambulance, we're going to take vital signs, okay? We're going to get all of our vital signs. We don't want to do this on scene just because it's a delay, okay? So we're going to get in the ambulance and we're going to take vitals. We want our blood pressure, our heart rate, our respiratory rate, and our SpO2, bare minimum, okay? Feel free to quickly listen to lung sounds if you'd like to. Don't worry about it at the same time because you're going to get it in your secondary, okay? Then we're going to get a sample history. Now, if our patient's unresponsive, we obviously cannot get that. I'm going to tell my proctor, though, I would attempt to obtain a sample history, but my patient is unresponsive. Say, okay, guess what? You get the point, even though you didn't even have to do it. So now you just saved a bunch of time as well. Now, if my patient's conscious, I'm going to go ahead and go through a sample. Don't forget, too, you can also try to get a sample from bystanders on scene. Okay, if you're forward thinking, if you're thinking about it, try to get a sample on scene. Did anybody see her? Does anybody know her? Can anybody tell me what happened? Okay. So now we're going to move on to our secondary assessment. This is our head to toe. This is the bread and butter. This is where you're going to get all of your points, okay? This should be very, very detailed. We keep it simple. We're going to start at the head and go right down the body. We'll come back up to the arms and we'll try to assess our back as well, okay? Here's where you fail this test, okay, is when you're assessing the head. You're going to say, I'm assessing the head, and you look at your proctor, anything wrong? And you just wait for them to tell you what's wrong, okay? That's not competency. That doesn't tell me you know what you're doing. I want to see, okay, I'm checking my cheekbones, I'm checking my jaws intact, I'm checking pupils, I'm looking for raccoon eyes. I'm going to go ahead and look in the ears for any CSF, any blood, maybe a battle sign. I'm checking the skull for any indents, impressions. DCAT BTLS is an amazing mnemonic to have. Once I feel good about the head, I'm going to move on, okay? I'm going to check my neck. I'm checking the C-spine for any step-offs, okay? If I haven't put on a C-collar yet, this is now the time to put on a C-collar. I'm going to look at my trachea. Is it midline or is it deviated? I'm going to go ahead and assess for JVD, okay? So all those tiny little points inside that secondary assessment per body part is how you crush this portion of the exam. Please do not just say, I'm going to check the neck. Is anything wrong? Okay? That's how you're not going to get any points, okay? Then move on. I'm checking the collarbones. I'm checking my ribs. I'm going to push in, feel for any crepitus. I'm also assessing it for any bruising, okay? I'm going to go ahead and now listen to all my lung sounds to make sure I have good lung sounds. Now, say your proctor says you have very diminished lung sounds on one side. I can't fix that, but I can note it and tell ALS or I can tell a doctor, okay? So make sure you're noting everything that you're finding. I'm going to move on down to the abdomen. I'm going to do my upper quadrants. I'm going to do this rolling motion, okay? Rolling motion, rolling motion. And I'm asking, do I have any distension? Does it feel hard? Is it soft? Is it tender? Is there rigidity? Okay, I'm basically trying to figure out if my patient has internal bleeding, okay? For our male patients, we're going to go ahead and do a genitalia sweep. Make sure we don't have a priapism, okay? For female patients, I'm only going to actually look at the genital area if there's major bleeding, okay? But again, to get your point, you need to tell your proctor, I don't find it necessary to check genitalia at this time. The proctor's going to say, okay, and you get the point. And you move on to the hips. We're going to push in and we're going to push down, okay? If it is unstable, this is the one thing that we are going to fix immediately, okay? So much internal bleeding can happen here. So if this is unstable or I have crepitus, I'm going to put on a pelvic binder, okay? You don't necessarily have to do that. You have a partner. You say, I'm going to have my partner put on a pelvic binder right now. I'm going to move on with my exam. Perfect, okay? So then we're going to start at the legs. I like to do a kind of a push and opposite to make sure that bone is nice and strong. Now remember, if this is actually broken and you come in and just put all your weight into it, probably going to severely hurt your patient, okay? So kind of go soft, feel for swelling. Is there any reaction from my patient? Okay, now I can actually give some pressure to feel if that bone is stable, okay? Move on to my knee. Is my knee intact? I'm going to go down to my tib fib. Do I have any DCAT BTLS? Now say this tib fib is broken. Say, yeah, it's swollen. You can tell that it's absolutely fractured. Copy that. I'm going to note it. I'm going to come back to it. Because I don't want to start treating this broken leg and accidentally miss a bleed somewhere else on the body. Okay, so this is not life-threatening. I'm trying to find life threats. Okay, perfect. I'm going to note it. I'm going to come back to it. I'm going to assess my ankle, ensure that it's intact. I'm going to assess my foot for any breaks, any DCAT BTLS. I'm going to do my best to check CMS. Now, if they're unconscious, can't really check CMS, but I can go ahead and check and see if I have any cap refill. I can also swipe my finger on the bottom of their foot and see if they react at all, okay? I'm going to do the same thing on the other leg. I'm going to come back up now to my arms. I'm going to check the shoulder. I'm checking my humerus, DCAT BTLS, any fractures. I'm checking my elbow, ensure that it's intact. Same with my lower arm or my radius and ulna, my wrist. Okay, then I'm going to check CMS. Again, if I find an injury that's not life-threatening, I'm going to save it for the end. I'm going to do the same thing on the other arm, okay? Now with this patient who's in a vehicle accident and say they're unconscious and we're in a moving ambulance, I'm probably not going to roll them and assess their back and unbuckle them, okay? What I would try to do is maybe kind of get underneath their back and feel for any step-offs or feel for any bleeding as best as I could, so I'm not causing further injury. When I would really try to assess the back was on scene when we either put them on a backboard or a scoop stretcher or pulled them out of the car, okay? Now, it's okay if you can't check the back, but you have to tell your proctor. I would assess the back, I would assess the sacrum and coccyx for any injuries, but with my patient lying supine, I don't find it safe to effectively assess that, okay? I'm trying to say, awesome, this person knows what they're doing, I'm gonna give them the point anyway, okay? Now, last thing that I'm gonna do is manage my secondary injuries. So I have a broken left tib fib, and we'll say I have a broken humerus. I'm now going to splint those. Perfect, we're managing our secondary injuries. All right, proctor, I will then also be reassessing this patient every 5 minutes. Once you say that, you are complete with this exam. Okay guys, that was our trauma assessment sheet. If you guys have any questions, feel free to email us, call us, or check out our website.